I want to move on to something that really more important and probably hip resurfacing to you guys in the audience, though, because this comes up all the time, and it really comes up in resurfacing patients. This is when you get hypotensive, lightheaded, pass out, whatever you want to call it, after an operation. Commonly happens after hip resurfacing. As I delved into this and been working for some years now, this really large database, find out that actually it's not very unusual to get hypotensive. The older you are, I have this if I get up in the middle of the night. If you're 80 years old, it's normal. More people than not are going to have an episode of this. We think it's very abnormal in the recovery room. Here, and if you do a hip replacement, 25%, not so much after a knee. There's good reasons behind all this why people do or don't get this. Cervical spine is another fairly common reason you'd get it. What do you call it? You know, I get it described to me, oh, your patient's bradying down, his blood pressure's cratering, very inflammatory statements sometimes that really are scary to listen to. I get scared when I hear them, try to overcome it. I call it fainting. It sounds not like you're going to die or anything bad. Because we see it in the office all the time. If you're up in your orthopedic office, you give a person who's kind of a wuss an injection, they just faint, keel over on the exam. We don't think anything of it. We prop them back up, and we try to get them out of the room at the same time as everybody else. The ER calls it this medical term syncope. And I was down seeing one of my patients a couple of weeks ago. I really got upset because they were doing the syncope workup. One of my patients fainted, but he had to have a CT scan, an EKG, had to go into the hospital and be on telemetry. It was given a big name of syncope, sounded really scary, cost a lot of money, and took a lot of time, but he actually just fainted. And the ER doctors did it from the doorway without examining the patient first, right here at our hospital. Said, we're going to follow the syncope protocol. Didn't have to talk to the patient or examine them. So I'd gotten there by the time this was happening. So careful what you call this. Orthostatic hypotension, mostly what we call it here. We're all in at Swedish on MAP now. Found out this in the middle of the night a few months ago. Mean arterial pressure. It's not a reliable measure of hardly anything, doesn't look like to me, but we have some strong rules. It says it should be 65, and if you don't have that, well, shame on you. You should have it better. What does it mean? It doesn't mean a thing. I have patients come in the office, they don't have a mean arterial of 65 when they come into the door. I don't know what to do with that number, but what really matters is your patient really okay or no? People have to be okay. They have to be safe. They have to be not in any kind of jeopardy. It's everything. And what does that mean? Well, we know what this means. You can think clearly. You are okay. You can say so. Your family around you can verify, yeah, it seems to be okay. We can measure it when we need to in objective fashion. Beyond that, urine output is a really good measure of perfusion in the end. If you don't have enough perfusion in your kidneys, you're not going to make urine and you've got a problem. You've got to be perfusing your kidneys. And people who go into real shock, they have poor urine output. So our patients typically with this, they don't have that. And we can measure it any way we want now, have them urinate, take an ultrasound on, and then oxygenation also. So your blood pressure is not very good. Your pulse usually isn't rapid, but it might be because you're anxious, you have had surgery. But oxygenation is typically good and needs to be. If your oxygenation is not good, you don't have good urine output, and you're not thinking clearly, you do have a problem. And you don't need your mean arterial pressure to be off. You still have a problem, even if your mean arterial pressure is good. So this is the database I've worked now, 892,000 cases. It's taken forever, but AI is helping me. I've got a pretty good research assistant. She's been with me. Well, she's 76 years old now. Jan's helped me for, I don't know how many years, 40. And so we were able to really get through this stuff. And in the end, in this database, these are people who've had hip and knee surgeries, 17% of the time you could find this somewhere in their record. So it's pretty darn common. If you're at a hospital, it gets really meaningful. So 52% of people at hospitals, they can't go home, and they said they were going to miss their ride home. Don't go home at all. Something not very good happens. Sometimes I had a patient, she did leave AMA, but she got put in the ICU. She was fine. She left there on her own. She got fed up and left in hours, but it was a pretty drastic reaction to it. At ASC, where I've done in recent years a good many of my cases, it's not quite as drastic. It still happens, but only 1% of the time does somebody get sent to a hospital for it. So if you're at a hospital, you get in the hospital. If you're not, you really don't. So that's pretty interesting. Now, the last thing is what really matters, though. What's the harm? There's no difference in whether you're going to have a stroke, a heart attack, renal issues, or death, and falls, same thing. It doesn't make a difference whether you had these 17% people. This database is so big, you can compare the incidence of these dreaded complications, which are terrible and serious, and we think our patients might get, but do they get it more often? It's like nobody ever gets a complication, but they don't get it any higher whether they had orthostasis or not. That is not the driver of whether you get these terrible medical issues. And which is meaningful when you're trying to talk to your patient correctly about what's the risk. They're orthostatic. What does it mean to them? Now, we know people who are going to get it, female, people who are fearful, naturally fearful, at risk for this, people who are pain intolerant, they get it. They just, they faint. Everybody knows this. These are people who are going to faint if they say they can't take a needle stick. These patients describe their own orthostatic event often. Prior history of it. We don't take that, but we should, because a lot of them can tell you they've had prior medical experiences where they passed out, they fainted, they had to call 911 on me, or whatever they want to tell you. You can get a history of a good many of them. So look for this, because it's meaningful. Measuring the arm blood pressure, it doesn't help much. It doesn't correlate very well anyway with stuff. That's what we do. We're doing it electronically now rather than just pumping up a tourniquet. The other things, blood loss is not the driver of it. We don't anymore get a lot of blood loss with joint replacements. Opioid use is not consistent. Risk factor, some people can take a lot of drugs. You're certainly hearing about that before. It's usually the first 6 hours, but it does not have to be. I've taken most of my own phone calls for the last many, many years now, and I get called the next day sometimes. People have they pass out. So it doesn't have to be. Doesn't have to be immediate like we're thinking. It can be later. And that's, we just had a patient that had it, and his wife was a nurse, panicked, but it was the next day. So what causes that, surgical types of shock? This is from Blaylock's work. And it's emotional. There's a neurologic basis for that. Sympathetic nervous system mediated, typically trauma. Sometimes there's anesthesia residuals. You need to give a block if you're going to do it. Certainly a hip resurfacing, so the brain doesn't realize your native natural hip was dislocated. So that's a way to get around it. How do you treat it? Reassurance. It mostly start with yourself. You got to overcome your own panic. Reassure yourself you're going to get through here. You got to have a calm demeanor when you talk to your patient, because it's scary. It still is for me. I try to overcome it because he's calm, but I don't know that describes me internally. Fluids, we can't anymore anyway. So forget fluids. I guess we're done with that. It's been a painful 40 years. We didn't give any of these fluids when I was training 40 plus years ago anyway. You could do 3 patients, 3 operative procedures. We'd leave a glass bottle up. We'd run in the patient, do 1 case, leave that same bottle up, bring the second patient in. We'd do 3 cases, 1 bottle of fluid. No kidding. Then we sterilized ourselves at the hospital. So educate your patients. Tell them about this. We give them a handout. Tell them this could happen. I tell them it could happen. Tell people this could happen. It's a known thing. Make sure they have somebody with them though after, because it's not a nothing burger. When they get it, you got to make sure, somebody has to, check them out. Fall risk is there. They don't have more injuries than other patients, but it's still a worry a little bit. But you got to educate your patient pre and post op. There isn't any treatment. Merle Haggard said this, but this is one of these things you can putz around, do what you want. Everyone's got their remedy, but I don't see anything that reliably works to mitigate this. It just kind of blows over. It will in a few days. Anyway, I'll go back to resourcing if we have any more time. I want to make sure I got that because I spent a lot of years on that topic, thinking about, worrying about it. Nothing's caused us more conflict with our nursing staff and with our patient families probably than orthostatic hypotension. I'm waiting for the emails coming from the hospitalists and but the next time, tell them, can you show me your last 890,000 cases you analyzed, showing me your map of 65 is required. I got real numbers behind what I said.